Today, we're going to be talking about communication, the role and importance of communication with your care team. We're actually going to be talking about a couple of things. We're going to be talking about the care team, who that is, why it's important to communicate with them, and then kind of discussing what you should be communicating with them about regarding off, and some statistics that we have based on the survey that we collaborated with Kiowa Kieran and the Davis Finney Foundation earlier this year. So some of the data has sort of informed what we wanted to talk about, because there are some standout pieces of information that we felt we wanted to communicate and make sure that care partners are aware of and try to help address maybe some information gaps. So one of the things that we found in this survey was that 49%, about 50% almost, of care partners say that they only sometimes talk to their healthcare team about their loved one's Parkinson's symptoms. 23% report never initiating calls. And we're going to be talking about why that's an issue, why it's important for you to be contacting the care team, when that should happen, and what you should be communicating. And one person said, in some of the opportunity to share some feedback, is that even when they do reach out to the care team, it's often hard to comprehend the majority of what the physician is discussing around Parkinson's progression or new symptoms. We know that we talk about off quite a bit, but it was interesting what we found in our survey, that while people feel a sense of understanding and feel pretty secure that they understand what off is, what the actual ability to identify was completely different. And I'm going to share some more of that statistic later. But we want to focus on why communicating with your healthcare team is important. We also want to talk about the fact that some of you may not even live in an area where there actually is a comprehensive care team under one roof. We know that not everybody goes to a comprehensive center of excellence where all of the team players are there and accessible to you at any time. Some people live where they have to drive hours to see a movement disorder specialist. They may have to really work hard to develop a care team. So we want to talk about who should be on that team and how you might be able to develop a team, even if it's not available to you under one roof, or maybe even in the same town, and why having that information accessible for you, for your family members, in case they need to step in and be aware of what's going on, and then sharing your different team members with all of the people that you're working with. Who is your movement disorder specialist? Who is your neuropsychologist? Who is your speech therapist? All of those different team members are key to managing your symptoms and improving quality of life, and the importance of communicating with them. Now, you should have, if you registered in advance, a couple of hours before today's program, should have gotten a couple of handouts as part of your toolkit. The first one is what we're going to focus on first. This is your interdisciplinary network of care. If you didn't get it, we will make sure you get it in an email. Kelly can probably drop some links for you in the chat. So if you haven't already, open up your chat box, because I see her dropping those in. Give us a shout out where you're joining us from, and that will be where you ask your questions. Today's discussion is going to be conversational style. So we're not going to have slides. This is a conversation with Dr. Rodriguez, and I'm going to introduce him in a second. And we want you to be interactive. So ask questions, make comments, whatever. The other piece that you got or will be getting today is your wearing off checklist, which will be referenced. We're not going to necessarily walk through all of these today, but we want to reference that information. And these are the topics that we're going to be discussing. So with us today is movement disorder specialist Ramon Rodriguez. He is with Neurology One in Orlando, Florida, my town. And he Probably you've seen him on one of our NeuroLife Online live streams before. He's one of our physician advisors, and he is actually in his own situation where he has a private practice, but is developing his own network, even though they may not all be under his roof. We want to talk about how he's done that and how you can as well. So I want to welcome Dr. Rodriguez.
All right. Thank you, Anissa. Thank you for the invitation. It's just wonderful having the opportunity to meet with your audience once again and talk about how to better the lives of the people with Parkinson's disease. And actually, not only for the patients to understand, but the caregivers to also understand what resources might be available.
Awesome. So I want to start off really kind of the basics right now. So I know most people know what a movement disorder specialist is, but sometimes we get people that are newly diagnosed and we don't want to make an assumption that everybody knows everything. So could you just briefly describe this subspecialty and how having a movement disorder specialist can benefit a person with Parkinson's and the care partner?
Definitely. So let me share with you. So I'm gonna explain a little bit about how my training occurred to have a better understanding, right? So typically, when doctors, even movement disorder specialists, we graduate from medical school. And after that, we move on and do a residency. And a residency is a period of 3, 4, 5 years where we are mainly doing neurological work. So we're seeing people not only with Parkinson's, but we see people in with strokes, multiple sclerosis, seizures, back pain, peripheral neuropathies, and just many, many other conditions. But the main challenge, Anissa, is that this training typically happens in academic medical centers, and these are the big hospitals. So when we finish our training as a neurologist, we are very good at strokes, multiple sclerosis, seizure, but the management of people with Parkinson's disease, because this is something that happens mostly in the outpatient setting, meaning not in the hospital, but in the clinic outside. Unfortunately, it might be possible that there is not a lot of exposure. And I have to tell you that, when I was doing my residency, I probably had maybe 3 months of exposure to the outpatient clinics. And it was there where I was going to see people with Parkinson's disease. So let's say that I had one patient with Parkinson's disease a day. That means that in 3 months, I saw maybe 30 to 45 people with Parkinson's, right? So we get some exposure, but it is not the best knowledge about it. So as a movement disorder specialist, when we finish our training, we actually decide to continue our education, and we do what is called a fellowship. And a fellowship is a post-residency educational program that it might last 1, 2, or 3 years. And during that time, all we're doing is Parkinson's disease and other movement disorders. So seeing people with tremors, trouble walking, the typical features of Parkinson's, dystonia, Huntington. And not only we are doing clinical care, but we're also doing research about these conditions. So just to give an example, in 1 week, I probably saw, as a fellow, I saw probably more people than I saw with Parkinson's disease during my full residency. So we were seeing about 20 patients a day with Parkinson's and similar conditions every single day. So by the end of my fellowship, I saw thousands of people with these conditions, their complications, and I heard to their caregivers, right? So we developed this experience just because we're doing the same thing over and over and over, and we can tell better and recognize what kind of patients will benefit from one treatment compared to another. So that's what makes a movement disorder specialist. We're just doing this all the time.
Well, and you're also often involved in the research. Yes. As well for the treatments, correct?
That is correct. So we do research, both research that is sponsored by NIH, meaning a lot of that research has to do with treatments, but also mechanisms of the disease. Where is the thing coming from? And what can we do to slow down the progression of this condition? And also we participate testing the new medicine. So actually the big drug companies sometimes will come to the university and they will ask us to help them perform these clinical studies. And they do that because number one, they know that we have the patient population. Number two, we have the expertise on how to do this. And then number three, we understand what research is. And, you know, to do research, you have to learn about certain conventions and the rule, and making sure that we're watching for the best of the people that are participating in the study. So we already have that experience.
Fantastic. Now, of course, that's ideal, but there are some people that are just in areas where there aren't any movement disorder specialists out there. And just as a reference, can you give us an idea of how many movement disorder specialists are actually entering that specialty annually, just so we have an idea of maybe?
So let me tell you, you know, about 4 weeks ago, I was meeting with a group of friends, movement disorder specialists, and we actually were trying to come up with the numbers of movement disorder specialists in the US. So I think that there's about 600 movement disorder specialists in the US, and there should be between 1.2 to 1.5 million with Parkinson's disease in the US, right? So if you divide that number among the movement disorder specialists, it is very small. So in terms of how many people are going into fellowship, I have to say, you know, between 40 and 50 new doctors are going in. And you know what, there's going to be about just the same number that might be coming out, you know, and retiring, right? So it has not been a big growth. It's a lot better compared to, you know, when I started the practice, because we were only a handful back then, but now there's more people, but still we are in the 600 number and about 50 positions every year to become a movement disorder specialist.
Wow, 600 for the entire US is not very much. So I guess that segues perfectly into like the next question and what people can do. Number one, if they don't have a movement disorder specialist in their area, and you know, what are some other ways by developing a team approach, can they maybe still get good quality care?
You know what? The answer is yes. And let me tell you why. So multiple things happen in the past 10 years. So there are the past 10 years and then the past 3 years, the COVID years, right? So in the past 10 years, there has been a lot more recognition about Parkinson's disease, the importance of recognizing that more and more people are being diagnosed with Parkinson's. You know, 10 years ago, we used to say that there were 1 million people with Parkinson's. We believe that the numbers now are between 1.2, 1.5 to 1.5 million. And we're expecting by 2030, this number will just continue growing by another 20%, right? So a lot more people are diagnosed with Parkinson's disease. We're better at it, right? You know, in the past, they used to say that people, you know, we're just getting older, right? And we didn't pay a lot of attention, but now we know better than that. And with the recognition of making this diagnosis, we actually have been able to, and the creation of these movement disorder centers, right? And the organizations creating what we call the Center of Excellence. What happened is that other than training doctors, we have been able to train physical therapists, occupational therapists, speech and language pathologists. And the doctors were able just to bring all these people to join, like, hey, listen, you know, we're in this wagon, join us, because there is a lot of people that need to be helped, right? So that people eventually, you know, graduate from their academic programs, or they have to move for one reason or another. And I'm going to tell you something, Anissa, and I know this from you as well. You know, once you start working with the Parkinson's disease community, you know, there is this love that comes, you know, and this bond that wherever we go, that's what we do, right? We're talking all the time about Parkinson's and the new research, what is going on. And when these people move from the academic centers, fortunately, they join places and they bring those ideas and all that knowledge that they learn in the bigger academic centers. So over the past 10 years, all these things have been spreading around. And I remember 15 years ago, when I was doing this, seeing people, being a specialist for Parkinson was only something that was happening at a big academic center. Like, we didn't think that a doctor, a movement disorder specialist, could even be in private practice or survive doing this, right? So at that point, what is happening is that now we're moving into even private facilities or even private practice, or movement disorder specialists. We open our clinics, but we immediately recognize, or people gravitate to us that have experience with Parkinson's. And, like in my experience, there's people in this community that have a genuine interest in caring for people with Parkinson's disease. So we actually get together, I make a big pot of coffee or tea, I bring some cookies, and then everybody sits down, and then we talk about how we're going to make this better. So that is number one. So there is more awareness about Parkinson's disease. There is more awareness that this is not a just take a pill and go back home. There's an understanding that there are some interdisciplinary approaches to Parkinson's disease to make the life of people better. And that there's many people in the community that are very interested in this. And then the other thing is there has been a lot of education about Parkinson's, right? So movement disorder specialists and neurologists, we have been going out and, we get invited to speak in the big family medicine meetings and internal medicines. And we have a lot of regional programs where what we're trying to do is to teach other people, other doctors, how to recognize Parkinson's, understand the complications on the medicines for Parkinson's disease, and understand that it takes a village to care for people with Parkinson's disease. And that these people are already in the community. All we need to do is understand who's who, right? What they're doing and how we can connect with them.
And that's exactly what you've been doing, because you were at University of Florida at a center of excellence. You came to the Orlando area, you opened up a private practice, and you started interacting with all of those experts in the community and developing your own network of so people can have that comprehensive approach, even though they may not have an office within your practice. So that's something kind of what I want to talk a little bit about, because there's a lot of people that don't have that center of excellence, one building, one-stop shop area, or in their area. And so they can still develop that kind of approach. And if you could kind of walk us through some of those key things, and this will go with the handouts that everyone received or will be receiving. You can download it from Kelly, put the link in the chat, but it talks about what you called like the village. PMD Alliance has the ecosystem. It's basically kind of developing the same thing. Who are the key team members that people should be seeing, and how can they help them not only, live a higher quality of life, but maybe even recognize an issue, like maybe an off issue that it may be presenting itself differently than maybe what someone thought that it would look like. So I know that's a very long-winded question, but let's talk a little bit about who those key members are of that team.
Yeah, so well, in first place, obviously the patient and the caregiver, right? They are the center, and they are very important, because in first place there has to be the desire and the disposition to get better. So that's number one. And then the first part of the team is the patient caregiver team, right? And I'm going to tell you that 90% of the times, those caregivers, both males and females, if the spouse has Parkinson's or the husband, Usually those caregivers, doesn't matter if they're male or female, they're always very attentive and very dedicated to the patient, right? Then the next thing is you need your doctor, and ideally you will have a neurologist, you will have a movement disorder specialist caring for you. I always, obviously I'm a movement disorder specialist, so if you have the option of visiting a movement disorder specialist, great. If not, just make sure that you have a good relationship with your local neurologist, because they have a better understanding, obviously, about this condition that just a regular doctor. And yes, we try to learn about everything when we're doctors, but we specialize because medicine has advanced so much, right? But then there is another group of people that are part of this team. So in first place, we have the physical therapists, right? Physical therapists are critical. And I used to say 10 years ago that, the treatment of Parkinson's was carbidopa, levodopa, pramipexole, and whatever, rasalginine, seleginine, whatever it was. And then down the list, we will go. And then after that, you do some physical therapy and occupational therapy and so on, right? Now I actually change the way I do it. And I tell people that number one treatment is exercise, right? And a physical therapy might be the best transition to get into regular exercise program, because at the beginning, number one, we are scared. Number two, we don't know what to do. Number three, we want to make sure that if you do this, you have to do it safely. So, and many times I make a recommendation of a physical therapy just for the patients to have that, for the people to have the understanding about what are the exercises that are useful for their condition, then learn how to make them properly, right? And then after that, they can go ahead and continue doing it on their own. So the physical therapists will help a lot with balance, getting stronger, have better control of our bodies. After that, we have them join, they're joined by the occupational therapists, and the occupational therapists, after you start getting stronger and all that, they help you manage yourself in your house, able to get dressed, take a shower, brush your teeth, get in and out of the shower, do your activities of daily living, get in and out of a car, right? So the occupational therapy is critical because the goal of treatment is to help you maintain your independence, right? So the occupational therapy is going to be PTOT, and then the next one is the speech and language pathologies, right? So one of the problems that happens to most people with Parkinson's disease is that they develop something called hypophonia. And hypophonia is a lowering in the volume of the voice. So patients might start talking well, but then at the end, they might be mumbling a little bit. The volume will go down. It might be difficult to understand what they're trying to say, right? So what we do is we try to help patients do some exercises to improve the projection of their voice. And this is actually very challenging because we have great programs, and I'm just going to mention, and I'm going to forget some of them, but, LSVT, Power Up, Big and Loud, and so on. It's great programs for us to work on these kind of things. But the most important thing, and this is where that team, patient and caregiver comes, is that, you cannot be going every day or always to the speech and language pathologist, right? Because insurance and the medical system only has certain coverage. So it is important that the patient learns and the caregiver is also watching. So when the therapy time is over, they will be able to continue doing these exercises at home, okay? After that, we believe that part of the team is a good social worker, because we need to understand what are the resources in the community. And I am going to tell you something, even myself as a doctor, I have been doing this for 22 years now, and I don't know what are all the resources in the community, and I actually go to people like Anissa to give me some guidance about what can I do with this patient, what resources might be available. So that is very useful. The other team member is a good psychiatrist. And remember that people with Parkinson's disease might suffer, there's a higher incidence of depression, higher incidence of anxiety. And remember that people with Parkinson's disease will be, might develop hallucinations, right? Psychosis and delusions that might be part of the condition, might be a side effect of the medicine. So having a good psychiatrist on board that understands Parkinson's, right? and that is that, small footnote there, because that is very important. It's going to be critical because at some point, people with Parkinson's disease will need an evaluation from a good psychiatrist. Then after that, we need a good neurosurgeon for those patients that might benefit from having surgery like deep brain stimulation. We might need the help of a good GI doctor because there are some certain therapies. The GI doctor is the gastroenterologist. So we actually have some gastroenterologists here in town that have demonstrated an interest in the challenges of people with Parkinson. You know that people with Parkinson's have constipation. They can develop something called gastroparesis, which is when there is a slowing of the movement of the bowels, the stomach. And then there are some more advanced device-aided therapies, right, that might need to have a tube put in to be able to administer the medicine. So having that person on board will also be important when we're trying to develop these regional teams that are going to be helping our patients, right? So I think that comprises the core. Well, you know what? I'm forgetting one, the neuropsychologist, right? So the neuropsychologist is important because every so often we may need to be performing some cognitive assessment, cognitive evaluation, so we can track what is happening over time. So I think that I'm sure that there's some others that I might be forgetting, but I have to say that the core, right? When I came into practice, the first thing I did was trying to reach out to these particular professionals in the community, because at least that will get us going in a very complete manner.
Absolutely. And there's one that you didn't mention, and I know you have an interest in, and that's the advanced practice providers, the nurse practitioners and PAs, in the role that they might play in partnering with the movement disorder specialist or neurologist.
So you know what, that's correct, Anissa. I am very happy that you bring that up because for people to understand, what we call the APPs, which are nurse practitioners, physician assistant. These are healthcare professionals that, while they do not have a medical degree per se, they have an additional training, right? After the regular training, they actually did additional training. They have a different degree where they will work along with doctors, and they will be learning the ins and outs and the complexities of these kind of conditions. And why is this important, right? This is important because, just like I told you earlier, 600 movement disorder specialists, maybe about 50 programs, graduating between 50 and 60 doctors every year as a movement disorder specialist. Still we are outnumbered, right? So I have to say that there's a group of nurse practitioners, physician assistants that have demonstrated interest in the Parkinson's disease community and people suffering from this kind of problems. And what we ended up doing is we have them join our practice and we train them, right? That's the first thing. That's the most important thing, because they are very well trained, typically in issues of primary care. That's the most common thing that they graduate. But now we're actually creating a program to train them as a movement disorders specialist, or the movement disorders knowledge. And this is very interesting because they become an extension of us. So, for example, and I'll tell you, in our clinic, we're typically very busy, and it's very difficult sometimes to even get an appointment in a timely manner, right? People call, the appointment might be 60 days, 90 days. Back in the day, when I was at the University of Florida, the waiting list was about a year. So that was just too much. Just imagine the desperation. So what we learn is, we have the nurse practitioner typically do the initial assessment of the patient. Still, me as a doctor, I go in, I sit down, I do my assessment as well. So it is a medical team approach. It is not that you see only the nurse practitioner and you go. So initially, while things are being sorted out and there are some complexities, we work together hand in hand, right? And then after that, you might have some visits that you will see only the nurse practitioner or the physician assistant. And the reason is it's only for medication management, and or it might be to to program the deep brain stimulator and so on. So they typically become very well trained doing this kind of thing. So one of the things that I'm trying to tell people is be aware that working with a nurse practitioner in the clinics is something that is very common. There is just no way that we will be able to meet the demand to care for people with Parkinson's. So we have been able to train a lot of these medical professionals. We work with them and they work under our supervision, right? And the one thing I tell people is that, you know, when your doctor have you follow up with your with a nurse practitioner, it's not that they are transferring your care or handing over your care. It's just that is something in between. We still meet at the end of the day. We talk about what happened in that visit. And then typically you will come back. We still direct the orchestra. Let's put it that way.
I love that. And, you know, that is so important to have movement disorder specialists like you really invested in that training of them. You know, PMD Alliance has our APP provider network where we support them and connect different nurse practitioners and PAs around the country so they can share what they're doing. And so having you doing that is so helpful, especially for people that don't have the access. Like I said earlier, sometimes those PAs and nurse practitioners are working in neurology practices with general neurologists, and then they get the training, and having the ability to go back into those communities and support that as an extension with that neurologist would be helpful. We had a question and I think that this would be good time to clarify. So when you were talking about the different team members, like the PT, the OT, the speech therapist, they're wanting to know, are they certified in PD the same as a movement disorder specialist? How do they become specialized in their you know, movement disorders in their space and their specialty?
So that is a fantastic question. So obviously, in first place, in the experience that I have with a lot of physical therapists, occupational therapists, and speech therapists is, in first place, and even today, right, we have them join our clinic. So they need to learn what is a patient with Parkinson's disease, and they need to hear firsthand what are the challenges that people with Parkinson's disease are going through. And they need to hear both from the patient, they need to hear from the caregivers, right? So these are people that typically join us. They spend a few months or shadowing in our clinics, just learning and absorbing, you know, all the information. They recognize, you know, what is raising of gait, what is a tremor. They understand the challenges about, you know, sometimes apathy, fatigue, you know, that will not let a patient be motivated enough to do these kind of therapies. And then there are smaller programs that are typically in their area. So for example, for physical therapists, there are these training programs where they will learn even more about Parkinson's disease, kind of mini certificates, even at time, or, you know, they get certified. For example, you know, what we were talking a little bit earlier, you know, the POWER program, Big and Loud, LSVT, and, you know, there are other organizations, you know, I'm blanking out on the name, but my wife actually even participated of one of the training, because she's a personal trainer. So she actually participated in a training and in a physical exercise training program for people with Parkinson's disease. And she spent a full weekend working with a group of professionals, just learning about, you know, the exercise component, right? So these people are very well trained. They are a step above. And this is very important because, once again, listen, as healthcare professionals, we want to help everybody. But there are some conditions that are a little bit more complex, more difficult to manage. And you have to have that trained eye, right? For you to understand what the challenges are. So that's why there's going to be some people that would have this interest. And I always make this comparison. You know, sometimes, at least in my area, right, you know, we have fantastic physical therapists, and some of them are trained into like knee problems. You know, we have here in Orlando Magic, and some other teams and all that. So they're specializing in shoulder problems and elbow issues and knee replacement and that kind of things, right? And they're the best, right? One time I actually had some back pain, And I went to this guy that he specialized in back issues, right? He was actually one of the physical therapists for the Florida Gators, right? And he helped me a lot. He helped me in 4 weeks what I wasn't being helped, with the previous therapy in probably 2 or 3 months. So that made a big difference. It was a learning experience for me as well as a physician, taking it firsthand as a patient, right? So these things are very important. So we need to understand that some people in the community, they have been training Parkinson's, and when you go there, you will see right away. You will see, how they're saying, okay, let's look at your tremor, let's look at this, and they will focus on the gait and the balance, and that is going to make the time that you're spending doing that therapy even more effective.
So this is good, because we have these people that are experts out there. They understand the disease. We have specialists like you and movement disorder specialists. And so we have the experts. What we need to do, and what we're finding is still maybe a challenge, is communicating to the experts as what's going on. So I'm going to shift gears just a little bit, because part of this program is not only addressing who should be on the team and why they should be on the team and how to kind of gather that team, but then once you have them, who you can communicate to and what you need to be communicating. So when we did the survey, we found that while many care partners felt very confident that they understood that they could identify off, and you were talking about the complexity of this disease, that is a very complex thing, 71% incorrectly identified off episodes. So if people are unable to fully understand off, and we have a lack of communication with the team, this is obviously going to impact the person's treatment and quality of life. So I want to talk a little bit now about off, because if 71% are still not fully grasping how it can express, and maybe it's not even so much of understanding the difference between wearing off and morning off and dose failure. Yes, I think that's one thing that we want to talk about, but maybe even breaking down some of the expression, both motor and non-motor, that people could be experiencing. So could you first just briefly review what are the different forms of off?
Definitely. So before I get there, let me make this clear. The conversation with your doctor about off episodes is going to be what will drive medication changes 90% of the time. Okay, let me say that again. When you understand an off and on episode, how much time you're spending off, and you recognize the symptoms, and you're able to transmit that information to your doctor, that is going to be critical, because medication adjustments are based on this information. If you are not able to bring this information, just like I'm hearing that 71% of the people in the survey had some issues, that means that 71% of the people do not understand very well what is the information they need to bring to that doctor's visit, so the doctor will be able to make the proper medication adjustment. Okay, so when we speak about off, we're talking about the time that the medications are not working very well. And what happened is that off presents in multiple ways, right? So the most common one is the wearing off. And the wearing off is your medications, not providing benefit as long as before. So for example, when a person is diagnosed with Parkinson's disease, they might start treatment on carbidopa, levodopa, 25-100, one tablet 3 times a day. And everything is great for 6 months, a year, 2 years. I don't know, everybody's different, right? But sometimes patients come back and they say, well, you know what, doctor, I'm taking the first dose of the medicine at 8 a.m., the second dose at 1 p.m. And back then it was lasting, all day I was feeling great. But now by 12:30, 12:15, I feel like the tremors are coming back. I have a little bit of difficulty walking, and my speech gets a little bit muffled or more difficult to understand. And then I take the medicine at 1 p.m. again, it takes about 20, 30, 45 minutes for the medication to start working, and then I'm back, right? So I feel better at that time. So what that means is that that patient was off for a period of about an hour, right? And typically when you are off, you know, you might have more tremors, you might have some problem with your speech, you might have some more freezing of gait, you might have some more balance problems. So this is why this is so important. Some symptoms might be mild, but some symptoms might have much more impact. So that's why it is so important. So then you take the medication at 1, the next dose is at 6, and typically that used to work very well, but now by 5:15, you're losing the benefit. So that's called wearing off. Then we have, and then people feel like slowly they're getting worse, you know, gradually they are losing the benefit from the medicine. However, some people lose the benefit suddenly in a matter of 10, 15, 20 seconds, like they were on and suddenly they lose the benefit. So we call that a sudden off. And then we have some people that they're just going from the on to the off and the on to the off. So we call that on and off fluctuations. And then the other type that we speak about is what we call the dose failure. And the dose failure is when you take your medicine, but you don't feel that you're getting the benefit from the medicine, or the delayed on, which is part of it, is typically it takes 30 minutes for the drug to start working, but now it took 1 hour and a half for the medication to begin working, right? So those are the types of off that people have, you know, people can have. Now, I'm just going to move on a little bit further, Anissa, because just like what you said earlier, the off can be motor or can be non-motor. So let me explain that, because people have issues with this, right? So a motor symptom is something that is related to tremors, right? Stiffness, slowness, anything related to movement, right? However, the non-motor symptom, we're talking about depression, anxiety. We're talking about panic attacks, anxiety attacks. Constipation actually is part of the non-motor. Hallucinations are part of the non-motor, right? So it's a completely two different set of symptoms. And we need to recognize them, because sometimes the non-motor symptoms can actually be more bothersome than the motor symptoms. And that's why we need to make sure that we're making the proper adjustments to the medicines, or using medications that will supplement what we are taking, right? Because those are, you know, not everything is just increased carbidopa, levodopa, right? There are now other medicines that will allow us to optimize the benefit that people will get from the carbidopa, levodopa, but recognizing this is very important.
We did have a question about whether taking carbidopa levodopa can actually cause tremors.
So, you know what, that's a great question, because while most people will have good benefit from the carbidopa levodopa, okay, there's still a small number of people, which is just like everything, right, that they feel kind of a paradoxical reaction. So when a person tells me that they're having more tremors or they take their carbidopa levodopa, typically my impression is that, number one, they are, you know, the medication might be causing some anxiety, right? And this happens because this is a dopaminergic. It's working, you know, it works with the brain chemistry, and some people are more sensitive than others. Then another thing that we try to answer is, what they're mentioning, a tremor, is it a tremor or a dyskinesia, right? So some people might have some symptoms and they call it, well, it's a tremor. Well, it's not a tremor per se, it's a dyskinesia. And it's actually caused by the carbidopa levodopa, but the cause and the implication is completely different. So listen, I'm gonna give you a great idea. Every time you see something like this happen, right? Take out your cell phone, here's mine, and record what is happening. Whenever you see an unusual movement, take out your cell phone, record what is happening, and then share it with your doctor. You know, like in my clinic, I have a platform where people actually send the video. They don't even have to come to an appointment. They just send the video, I look at it, and I tell them, This is what it is. And if it is something bad, I tell them, come tomorrow. We need to work on that. Or if not, like, listen, don't worry much about it. It's just part of the condition. And I give them some instructions about what to do. So the answer is yes. Some people might be a little bit anxious, apprehensive, and all that with the carbidopa, levodopa. The tremor may get worse, but many times we have to differentiate from a dyskinesia as well.
All right, I want to dive in a little bit deeper in regards to some of these motor related or non-motor symptom expression, because I think they get kind of confusing and also maybe overlooked when people are communicating with their physicians about OFF, and they're really important. So you've mentioned a few, but like maybe the anxiousness, the mood changes, maybe the slowed thinking. Mm-hmm. Can that be a part of it? And somebody, and I think this goes with the question Barbara wrote about sundowning. What's the difference between maybe an off episode where there's maybe cloudier thinking or delayed processing versus somebody who actually has sundowning?
Yeah, so in the when it is because of an off episode, right? Trying to make this simple. Typically, if it is an off episode, it will get better after taking carbidopa, levodopa, right? So the sundowning phenomenon is a phenomenon that tends to happen later in the day, 6, 7, 8 p.m., where the patient develops this slow thinking. They might be confused. Some people might have hallucinations. They might become irritable. They might become restless. They might be pacing from one side of the house to another, not following instructions, or they just fall asleep or, in a state that they're not much responsive, right? And if you give them a carbidopa, levodopa, it is not going to do anything. It's not going to make a change in what is going on versus when a person is going in the off medication state and they might have a little bit of slowness of thinking and movement and their abilities, typically taking the next dose of the medication will help improve those symptoms. So that is probably the best way to determine whether is this an off episode versus is this just sundowning that is happening because of a fluctuation in mental status that is associated with the disease itself.
And things like increased stress, impulsiveness in behavior, are those things that people might see in OFF?
So while you might see it more in OFF, those features like impulsiveness and all that, it can be both. Impulsiveness is something that sometimes might be associated with Parkinson's disease itself, the primary condition, and some of the medicines as well, mm-hmm. right? So some of the medicines might facilitate compulsive behaviors, impulsiveness, gambling or working too many hours in the yard, or the other day I was seeing a patient via telemedicine and he just would not stop pressing the buttons in the computer, right? So he just couldn't do it. He just couldn't stop. And it was a side effect of the medicines that he was, that he's taking for his Parkinson's disease, unfortunately.
And you made such a good point, because there are things that are caused by the treatment. There are things that are caused by the lack of treatment, and combing those out is really challenging. And that's why, being aware of what's a potential symptom or side effect of medication and communicating those is so important, because the doctor is the one that's going to be able to help with the information that the person with Parkinson's and care partners supplying to them.
Yeah. So, and the best thing that a person can do, especially caregivers, right? Find the association. Is this happening always at 6 p.m. or is this happening after he takes his carbidopa, levodopa, or before the carbidopa, levodopa, or is this associated with any other medicine, right? So it is critical that you try to make this association, because otherwise we will not be able to help you much.
And there's some autonomic symptoms that can occur with OFF. Is that correct? I know somebody was wanting to know about excessive sweating. So can there be changes of sweating and then chills, maybe dizziness, any of those types of symptoms?
So Anissa, yes, talking about autonomic nervous systems and symptoms, dysautonomia, I think that we can spend the whole weekend and we will not finish talking about them. So let me tell you, so one of the complications of Parkinson's disease actually is that people might develop this thing that we call dysautonomia. And dysautonomia to me is probably one of the most disabling non-motor features of Parkinson's. Probably the most common one is the orthostatic hypotension, right? Which is when people feel dizzy when they're standing up. And they stand up and the dizziness might happen between the time they stand up and the next 10 minutes. I just had a patient come yesterday. He had fallen 7 times the day before. Can you believe that? And then, so I asked them, and actually that this helped, I asked them, and he's been falling for the past 3 to 4 weeks, right? Initially 1 or twice, but yesterday, it was 7 times. And I asked him, but how this happened? Well, doctor, most of the time he gets up and he's trying to go to the bathroom or trying to go to the kitchen. And within a minute or so, that's when he ends up passing out, right? Or falling down. And immediately that is almost diagnostic, right? And I asked him, do you feel dizzy? You feel like something's coming? And I say, yeah, I feel it. So that's part of the Parkinson's. And unfortunately, sometimes the carbidopa-levodopa might trigger it, might facilitate, not only carbidopa-levodopa, the medicine for Parkinson's overall might facilitate that this is going to happen. So, we need to address, you have to drink more water, use the compressive socks. There might be some medicines to help keep the blood pressure up and so on. But excessive sweating is something that is observed as well. And especially during the night, I have caregivers that tell me, sometimes we have to wake up in the middle of the night and change the bed sheets because they're soaked. He's been sweating all night long, and he cannot sleep then because everything feels wet. So yes, we can see these kind of things.
Wow. And I'm curious, things that might seem less obvious than maybe sweating or, dizziness. Like if somebody's experiencing off, can they do things like just kind of stare off or seem like they're in another world? Is that potentially part of it?
It is because some patients develop something called bradyphrenia, and which is a slowness of thinking. It's kind of the world is in slow motion, right? So obviously we live in a fast world. We want everything fast. So, hey, Johnny, what do you want for dinner? And then he's slower, right? He might be in the off state. He's not as quick responding. And then the caregiver, is trying to do things fast, right? Or do what they needs to be done, right? Everybody's very busy and we really want to help, but this will be the time of occasions that, if the patient does not give an answer right away, I have a patient that it takes about 20 seconds to give an answer to anything. And I tell the family, listen, you just have to be patient, right? And I understand their desperation, right? They want things to happen more fluid. Let's put it that way.
Well, and I think this is really important for people to learn because that is something that could easily be overlooked, but obviously has an impact on the person living with it and those communicating with him. I'm just curious if you could spend a minute, I know we're getting close to the end, talking about, this I think underscores the importance of understanding, communicating what is going on, but what are some of the impacts has on the care partner? Like, if these things are not addressed, can you just, I know that's a loaded question for just a few minutes, but can you just kind of talk a little bit about, how this can be impacting care partners if they're not addressed?
So what, it affects the caregivers and the care partners immensely. And I always say that when a person at home has Parkinson's disease, to some extent, everybody has Parkinson's disease, right? Because everybody, with a lot of love will adjust to the new situation, right? But sometimes, it happens that these symptoms are very disabling. I'll go back to the example from yesterday. The patient is 81 years old. He fell 7 times. The wife is 80 years old. She has her own medical problems. just imagine the distress, right? You know, she had to call a lift team or somebody. Fortunately, they live in an assisted living facility and somebody was there, right? But just imagine this at home. That, you know, if you live in the countryside, how bothersome and how much this can impact your regular life, right? And many times, I'm going to tell you something. Patients tend to minimize the impact of these things, and they do not recognize that it's taking a big toll in the caregivers, you know, and this is where the term of caregiver burnout comes from, right? Where they need help, you know, they feel fatigued, tired, and they feel like they don't have full control about the situation, and this happens because they want to see their loved one doing very well, doing a lot better. Nobody wants to see the person they love falling down or having anxiety attacks, panic attacks, or just sitting there, you know, immobile, right? So yes, this has a major impact in the caregiver, you know, both physically as well as mentally, right? And these are things that need to be addressed right away.
Absolutely. And in fact, I think that leads right into discussing that the next program that we're doing on November 9th is actually focused on the experience of the care partners, their challenges, and the impacts the caregiving has on them. And this all relates to, you know, if they're not optimized, if their loved one is off, if their symptoms are, you know, fluctuating so much, if they're falling 7 times, that is a huge stressor. And so we want to focus a little bit on that. We did have a question. This is being recorded, so you can access this. I'd say by Monday, it should be up on the website. And Kelly dropped the link into that. Kelly's also going to drop again one more time the links for the handouts today, because they really go along with what we've been talking about. The first one looks like this. It has our ecosystem on the front of it. It's the interdisciplinary network. It literally goes through each individual, I know you can't see it very well, but each individual practitioner that is in that network, your primary team, which would be your movement disorder specialist, your advanced practice provider, the secondary team would be your psychiatrist, neuropsychologist, GI, urinary, all of those, what they are, and an opportunity for you to, if you don't already have one, look for one and develop that team for yourself, especially if you live somewhere that there isn't a comprehensive team. And then the other handout is a list of symptoms, both motor and non-motor, that you can go through with your loved one and identify whether they're experiencing that symptom and whether it improves with their medication when they have it, and whether they have any changes when the medications are wearing off. So help you to identify, is this actually something that you need to tell your physician about? And so those are available to you kind of as a supplement to today. But can't thank Dr. Rodriguez enough, because you explained this all so understandably, so clearly, and really in a way that is very helpful, because I've learned a lot just listening to you.
Well, thank you so much. And you know what? Now that you're saying this, I actually forgot one team member, right? And these are organizations like the PMD Alliance, right, that are trying to you know, for the audience, for you guys to understand, you know, the members of the PMD Alliance, they're creating collaborations and a lot of connections with us, the doctors, right? And they're always reaching out, and they're asking us, you know, what is happening, you know, what kind of needs are in the community that you think we can serve them, that they would like to know more, and so on. So they're reaching out, and they're creating all these educational program, and they're looking for people that will help them have new programs and education and fund them, and just about everything else. So once again, you know, that is a critical member of the program. So it's critical that you guys stay connected, stay in the loop, right? I'm in the email list. So every time there's an event, from one of my colleagues and all that, I try to log in. So I actually see how they're, what they're saying, what they're talking about, because I always learn something that I might be able to transfer for myself to care for my patients. So obviously you guys stay on board, listen to the programs, participate, bring your questions. That's the most important thing. Bring your question, because I'm sure that just like me, they want this to be useful. They want that, the time that we click leave the program, you have some information that you will be able to transfer and use for your, your own experience at home.
Awesome. Well, I want to thank you so much and thank Kyowa Kirin for this partnership to be able to bring this information and this program to everyone. And I want to invite all of our listeners to thank Dr. Rodriguez with the wave of gratitude that PMD loves to send you off with thanks for, because this is fantastic, so helpful. Everyone's saying fantastic. Thanks for the great information.
Thank you so much. It's a pleasure. It's an honor all the time to be with all of you.
Well, thank you. And I hope everyone has a great weekend.
Same. Bye-bye.
Bye.